Now moving towards our third talk, I request Dr. Sanjay Kava to come on the dais, and his talk is about an interesting neurological case and discussion. Dr. Sanjay Kava is our new APR member, though he is very senior. And one thing I would like to tell everyone that he has taken retirement from the ISRO Harikota. He was working in a space medicine, and now he is taking our third talk. It is his first talk in our APR monthly meet as a new member. Over to you, sir.
Good evening, every APR members, seniors, and actually I have passed MD from MP Shah Medical College Jamnagar in 2001. Then I have started my private practice in Verawal, Somnath. In 2007, because of hectic practice and some academic interest in space medicine, I have joined Sri Harikota, Satish Dhawan Space Center, Andhra Pradesh. I was committee member in human space flight missions. At that time, Chandrayaan 1 and 2 was going on project. We have submitted a study report on that. We have to maintain health of astronaut, and we have submitted a study report. But due to some government policy and that project, it was not on project mode. So that's why I came to again in Gujarat because of some relatives. Garno doctor kind. So in 2009, I have joined Kakrapat hospital. It was under Department of Atomic Energy. So 10 years, and it was there was a rule after 15 years there was a compulsory transfer to the Narora, Delhi. So I have taken ERS, and last 6 months I have joined HCG hospital as a visiting physician. તો અત્યાર સુધી કોઈ રાજકીય પક્ષ જોડે કોઈ જોડાણ નથી. Thank you for giving opportunity, APR members. So today I will present a rare case of neurological disease. It was not here in KPS hospital. A male patient, 18 years old, presented with right upper forearm and hand weakness since 1 year. It was insidious onset, and weakness progressed slowly up to 6 months. Then it stabilized. There was no more progress. History of muscle twitching, means fasciculation, since 3 months, and he was unable to pick up a pen or spoon, and unable to hold tightly since 1 to 2 months. Patient has also complained of difficulty to flex the elbow. There was no history of fever, trauma, weight loss, or no history of any sensory symptoms or sensory loss. There was no weakness in other limbs, in left hand or left lower limb. No history of difficulty in swallowing or speech abnormality, or no history of breathing difficulty. Past family history, personal history was nothing particular. On vitals were normal, and other systemic examination was normal. Patient conscious, cooperative, cranial nerve examination was normal. In motor system, muscle wasting in the intrinsic muscle of the right hand, particularly in inner muscles and first dorsum interosseous muscles, as well as wasting of the right forearm muscles. Muscle strength power was 3 to 4 by 5, and fasciculation was observed. Mild hypotonia on affected muscles. Sensory system examination was normal. On hyporeflexia on right biceps muscles. These are the picture. Because this is a 2-dimension, you cannot make out rightly, but this part you can see right hand. Somewhat wasting is there, and here you can notice. Biceps you can make out. There is a wasting of bicep muscles right hand as compared to left hand. So first differential diagnosis. First in my mind came that it may be cervical myelopathy. It was maybe due to some extra rib, cervical rib, or cervical canal stenosis, disc herniation. But there was a no neck pain with radicular pain, no upper motor neuron sign or gait disturbance. Second thing was brachial plexus pathology, neurogenic thoracic plate syndrome. But in this case, sensory finding was not. In this case, it was not present sensory finding. So clinically, it can be ruled out, and no pain in hand. Third was most common motor neuron disease was ALS, amyotrophic lateral sclerosis. But here also only lower motor neuron sign was there in our case. In ALS, upper motor neuron sign, and it was middle age disease, ALS. Other spinal muscular atrophy type 4. But in this spinal muscular atrophy, onset is early, 6 to 18 years of age, and it may, most of cases associated with lower limb weakness. Fifth thing was syringomyelia, but dissociate sensory loss is present in syringomyelia, but in our case sensory loss was not there. And sixth one is tephromelasy anteriorly. In this case, anterior wound cells ischemia or infarction due to spinal artery thrombosis, but it affect middle-aged adults and linked to arteriosclerosis and other systemic symptoms. And seventh was Hirayama disease. So in our hospital, 50-bed hospital, the first basic investigation I have done, it was cervical spine X-ray. And cervical spine X-ray, you see there is a loss of lordosis. Otherwise, it was for, I have taken X-ray for any cervical rib is there or not, or any osteophyte or any other thing. But you see the loss of lordosis. At that time, I was not aware why this is a loss of lordosis. But later on, I have correlated. Then I refer blood investigation basics, CBC, LFT, RFT, and HIV, HBsC, viral markers. All investigation was normal. And then I referred to neurophysician, Surat, for further investigation. So there no conduction studies was carried out, and it was showing the musculocutaneous nerve affection. So provisional diagnosis was made that early motor neuron disease may be there, and the patient came with steroids and other things. After 1 month, because it was not perfectly diagnosed, so I have talked to neurophysician, and second time after 1 month, because patient was studying in hostel, so second consultation was done, and at that time brachial plexus MRI was done, considering brachial plexus was involvement will maybe there, but it was normal. So then again, third time, we have carried out MRI cervical spine, but that was also normal. And cervical spine MRI showing only loss of cervical lordosis. Patient came back again with same early motor neuron disease diagnosis. After 2 months, I have again referred, and we have a personal discussion with a neurophysician, and then we go through again cervical spine with contrast in flexion position after 2 months of this first cervical spine MRI. So cervical, in that MRI, cervical cord shows the mildly increased T2 weighted hyperintensity at C3 and C5 vertebra, and posterior epidural space increase on flexion, appearing hyperintense on T2 image with increased post-contrast scan and reversal of cervical. See, you can see this. Here you can see this is a normal without flexion. Without flexion, you can see that there is no any indentation or durameter. Everything is okay. But here with flexion, you can see this crescent shape. So anterior cervical that posterior dural sac move anteriorly, and there is a indentation in cervical spine C3, C4, C5. So based on this MRI finding, they have put a diagnosis of Hirayama disease. This is the axial section of cervical spine of MRI. Here C5, because it is a original that I have taken in viewing box, it is not so much clear, but anterior posterior flattening of C5, C6, snake eye appearance, hyperintense signal you can hear C5, C6. Here you can slight flattening is there. Anterior posterior diameter will be decreased due to compression. Hirayama disease was diagnosed, first recognized in Japan 1959 by Hirayama et al. Reported under the name of juvenile muscular atrophy unilateral upper extremity. Various names suggested: monomelic hematrophy, juvenile asymmetric segmental spinal muscular atrophy, benign focal hematrophy, and most prevalent in Asian country, mainly Japan, India. In India, only 279 cases reported over 35 years. Last figure since 2019, only 279 cases reported. The main characteristic of this Hirayama disease is there is a male, it is seen in more in male, and age is between 15 to 20 years of age with insidious onset and asymmetric weakness and wasting of muscles of the upper limb, affecting mainly C7, C8 and T1. In our case, it is affecting C3 to C5. The disease progressed slowly over 1 to 3 years and followed by stabilizers. In our patient, almost it was diagnosed in 21, and almost 4 years is completed. So now there is a improvement in upper limb weakness, hand weakness, and slight weakness is there in biceps muscles. Otherwise, just before 8 days, I have talked with that patient, and he has sent repeat photograph also. That is almost looking normal. HD may be associated with coarse tremor in finger and fasciculation and sometimes transient worsening of symptoms on exposure to cold. The sensory system reflects cranial nerve examination in majority of cases are normal. Pyramidal tract involvement in lower limb, autonomic disturbance and cerebral deficit are also rare. According to Tessiro et al. Diagnostic criteria for Hirayama disease, distal predominant muscle weakness and atrophy in forearm and hand. Second criteria is involvement of unilateral upper extremity in most of cases. And third is onset between the age of 10 and early 20. Fourth criteria, incidence onset with gradual progression for the first several years, followed by arrest of disease or stabilizations, no lower extremity involvement, no sensory disturbance or tendon reflex abnormality, and exclusion of other disease by investigation like MRI and other investigation, blood investigation. All of 7 points were fulfilled by our cases, which helped to make the diagnosis of Hirayama disease. The EMG shows chronic denervation with or without acute denervation changes. In our case, EMG was not carried out. NCV shows reduced compound muscle action potential in affected muscle. Sensory nerve action potential are generally normal. Conduction velocity of both sensory and motor nerve are usually within normal limit. MRI cervical spine with flexion. There is an anterior displacement of the posterior dural sac along with crescent mass in the posterior epidural space of the cervical canal. The pathophysiology is, it is a hypothesis that the disproportionate growth between spinal cord and spinal canal, making the cord relatively short during teenage development. In boys, there is a development is more as compared to girls, so it is more seen in male individual. During neck flexion, there is a dynamic compression due to forward movement of dural sac and spinal cord leads to transient ischemic change to the anterior wound cell of the spinal cord, which affect the motor function of the arms and hand. The treatment is self-limiting. HD is a self-limiting condition without any definitive treatment. Cervical collar, it is useful. In our patient, we wear cervical collar up to 2 years, and it is useful and it recovers. Patient had recovered with the help of cervical collar. Cervical collar can used to prevent neck flexion, compression, and disease progression. Physiotherapy can also help for muscle strength. Whether surgical intervention is necessary or not, it is still debated and controversial. Surgery may be useful in selected cases, some rapidly progressive cases or severe cases, and fail conservative management. So in conclusion, Hirayama disease should be always be considered in young patient presenting with weakness and wasting of muscles of the hand and forearm. MRI cervical spine in neutral position and flexion position is necessary for the diagnosis of Hirayama disease. If diagnosed early, its progression can be stopped by simple management using cervical collar and can prevent surgical intervention later on. Excessive usage of mobile, laptop, computer in a young generation can aggravate Hirayama disease due to long duration of neck flexion. Thank you for time, attention, and compensation.